Good evening. I sincerely thank first Dr. Kalyan Chakravarti sir for accepting to be a speaker tonight and to Medtronics for arranging this wonderful event. Just scan it, open that web page and keep it ready. We'll use it later. So I'll be talking about introduction to insulin pump therapy, and I'm a physician and a dietologist at Caspian Healthcare, Vijayanagar College. Today's pump is the one that is there on your table. And when it was first invented, it was like this. So you had a backpack of a pump, just say insulin would get delivered. So just try to understand the improvement in the model that has happened over time, over decades. And not just the size has improved, but also the precision and accuracy of the pumps. My question to you is, why aren't we even talking about a pump when there are so many insulins out there who have so many insulins, literally. Rapid-acting insulins, short-acting insulins, co-formulations, premix insulin, regular insulin, basal insulin, and why do you still need a pump? Anybody?
We can't continuously monitor and keep on giving insulin. So the pump will enable us to monitor and also pump insulin according to the requirement of the body.
So for this, I want to take you to the next slide where I am talking about a few glossary terms. I'll just get them for your reference. CSII is continuous subcutaneous insulin infusion. That is technically what the pump is doing. MDI is multiple daily injections of an insulin. So some patient is taking 3 boluses, 1 basal. That's MDI. Basal insulin is the long-acting insulin that we give. Bolus insulin is the rapid-acting or the short-acting insulin that we use. Bolus desired, this is a term that we use for insulin pumps में एक feature which auto-calculates how much insulin should be given to the patient based on the carb intake, what is the sugar level right now, and how much is the active insulin that is present in the body. Active insulin time is something that prevents insulin stacking. Active insulin time is say 2 hours, 3 hours for a rapid acting insulin. उसके बाद में it tails off. Insulin to carbohydrate ratio is how much insulin is needed to take care of the carbohydrate that this patient is taking. Say he is taking 100 grams of carbohydrate. Then how much insulin do I need to give to this patient so that his sugars don't surge? Insulin sensitivity factor ISF is 1 unit of insulin can reduce how many mg of blood glucose is ISF. Time in range is that feature of a continuous glucose monitoring system which tells you for how much of the duration glucose was in range versus above range and below range. And the reservoir is, there's a pump kept on your table. The insulin reservoir is that cartridge that is inserted into the pump which stores insulin. And the infusion set is the tubing. Cannula is what is applied on the subcutaneous plane. Patch pump is Vigo pumps where you don't need the tubing, okay, they are directly applied on the skin. CGM is that sensor. SAP is sensor augmented pump. So there's a difference here. Here I come. Sensor augmented pump is, there is a pump which is not an advanced hybrid. You are using a sensor and वो sensor के reading से you are adjusting the insulin in that pump manually. That is a sensor augmented pump. Okay, the previous versions of 780G, the manual pumps. Those manual pumps, if combined with a sensor, and you are using this sensor readings to give the boluses, set the basal rate, etc., then that is a sensor augmented pump. CGM guided MDI is multiple daily injections a patient is taking and he is using a CGM to guide his dosages. That's a CGM guided MDI. And SMBG guided MDI is self-monitoring of plasma glucose is being done. Say he's taking his sugar 7 times a day, 10 times a day, and he's adjusting his insulin dosages and taking that insulin externally through a cartridge or a syringe. That's SMBG guided MDI. Hybrid closed loop is that integration of the pump with the sensor signals. So there's a transmitter with the sensor which transmits the interstitial glucose values to the pump, and this pump auto adjusts. The advanced pumps like the 780G, they check your sugars 288 times per day and adjust the rate of insulin delivery. That's literally every 5 minutes. 1 hour में 12 times. And Smart Guard is that feature which prevents hypoglycemia and gives auto corrections when sugar is going up. Low glucose suspend LGS is in the previous versions of the pump when the sugar would hit the low, say it hits 70 or below, then the insulin delivery would get suspended. That is LGS. Low glucose, suspend. However, now it is predictive LGS. Predictive low glucose suspend. Where if the pump thinks that in the next 20 minutes, in the next 30 minutes, my subject's sugar is going to go below 70, then it suspends the pump in advance. That's suspend before low or predictive low glucose suspend. If you have ever seen a CGM, say Libre ka CGM, then it gives you some arrows. Those arrows are like a steep up is your sugar is rising rapidly. Diagonal is your sugar is rising not very fast, it's 1 mg per minute. Here it's almost constant if it is like this, horizontal. If it is this way, it is dropping by 1 mg per minute, and if it is steep down, it is 2 mg per minute drop. So similarly, now the pump knows that if this patient's sugar is dropping by 2 mg per deciliter and his sugar is say 100 mg per deciliter now, in the next 15 minutes, this patient will hit 70. So it will suspend the delivery of that rapid acting insulin that it is delivering. And auto basal is that rate that you set. Auto correction is when your sugar is going up, and maximum basal was given for that hour. Now the pump is trying to give some corrections. That is auto correction, and this auto correction is almost it is done every 5 minutes again. Auto correction is also done every 5 minutes. Artificial pancreas or bionic pancreas this is something that we would ideally want. A complete artificial pancreas system for a patient with maybe type 1 diabetes. So this bionic pancreas is this pump plus alpha cell ka action also. The glucagon is also released, not just insulin. Insulin is from the beta cells. Alpha gives you glucagon. So if the pump is able to give glucagon and insulin as needed, then that is a bionic pancreas. A1C is your 3 months average sugar, glycated hemoglobin. Glycemic variability is again a derivative of CGM. You need to know Somogy phenomenon and dawn phenomenon. Dawn phenomenon is patient's sugar is rising at dawn. Throughout the night it was normal, but now it is rising, and that is because of the counter-regulatory hormones, adrenaline, cortisol, etc. They are causing a rise in blood glucose at around 5 a.m., 6 a.m. like that. That's dawn phenomenon. Somogy is again a rise in blood sugar, but due to hypoglycemia in the night. If you have to differentiate between dawn and somogy, dono mein there's early morning rise of glucose. How do you differentiate if it is somogy or dawn? You ask the patient to check 3 a.m. blood sugar. If his 3 a.m. blood sugar is low, 2 a.m. blood sugar, 3 a.m. blood sugar is low, what was it? Somogy. And optimized trial was optimize 2. So type 2 diabetes mein insulin pump therapy, and it showed great results. Hypoglycemia unawareness is patient is having hypoglycemia, his sugar is say 40, he is not aware that his sugar is 40. So such patients, they benefit from CGMS and ADM pump also. And temp target is temporary target, a fancy term for temporary target, which you keep when there is a higher risk of hypoglycemia. For example, a patient on the pump, if he's going for a walk, if he's going for a swim, then he should not be getting a hypoglycemia, right? So what we do is, his usual target is 100 to 120, and in temp target, we make it 150. Another advantage of a temp target is auto correction is disabled. So if sugar is going up even beyond 150, then auto correction will not be done by the pump until you switch that off. So now let us see how the CSII, continuous subcutaneous insulin infusion, has evolved. I told you the glossary because I'm going to use all of these terms throughout my presentation. So the benefits of the new technology. So it was a prototype insulin pump 1960s mein, and then the first variable insulin glucagon pump in the 1970s. Then auto syringe manufactured and marketed a big blue brick pumps similar to your batteries now. And biostat or glucose controlled insulin infusion system was introduced, something like a syringe pump that you use it in ICUs. Then the first Medtronic MiniMed CSII device, and then came CSII devices, became smaller and more user friendly. Artificial pancreas trials have begun in the USA 2012 mein, and the present day is 780G hybrid closed loop system, automated insulin delivery. So why pumps provide better control? So for this, one is it minimizes the insulin variability. And in the pump, which insulin do you use? Insulin pump hai, in the reservoir, which insulin do you keep? Rapid acting insulin. When you are giving rapid acting insulin continuously, it is like a basal insulin only. Ultimately, insulin in the blood is going to behave like any insulin, like a regular insulin. But how the depot how it behaves when it goes into your subcutaneous space is what makes them longer acting, intermediate acting, small acting, right? So here you are giving you are controlling the rate at which this rapid acting insulin is being delivered, so that it actually acts like a basal insulin. So you don't need a basal insulin for these patients on pump. And pump delivers insulin in two ways. It can be a basal or a bolus. The same insulin, it is delivering in two ways, the way the patient wants it. So basal, it replaces long-acting insulin. It covers the hepatic glucose output. Whatever liver is pouring, whatever the glucose is being poured by the liver into the blood, that this insulin takes care of. Which oral antidiabetic drug takes care of this? Metformin. Maintains glycemic stability in fasting states. So in between the meals and at fasting, this is what it is taking care of. Any basal insulin or the basal that the powder is creating, and automatically delivers precise programmed dosages. It adjusts to match diurnal variations. Now, my question to you is, when I asked you why these have become a reality, so the pain point was there is glycemic variability in each individual, and for the same individual on a day-to-day basis, intra-day basis, there is glycemic variability. So that is why it is very difficult for us to practically adjust the dosages for each patient. This is what these pumps do. And bolus, it covers for the food intake and corrects high blood glucose levels. The current pump that you have to manually enter how much carb you are taking. Say you say I'm taking 100 grams of carbohydrate. Then based on the insulin carbohydrate ratio, say you have kept it 1:10. So it gives 10 units of insulin bolus to the patient. And the pump uses a bolus wizard calculator. It calculates insulin boluses, food and the correction. If you have seen inpatient management of blood glucose, what do? Say we keep one basal insulin and then 3 rapid acting insulins. And say we said 6 units is what we had planned. 6 in breakfast, 6 in lunch, 6 in dinner. And now your pre-lunch sugar instead of 120 is 250. So what do? Yahan you take that auto correction also, and that correction factor also, and to that 6 units you add 2 units additionally so that post-lunch sugar again should come to maybe 160, 170. That you are doing it manually for your patients. This wizard does it for you. Okay, you just have to tell him, I am taking 100 grams of carbohydrate. And it sees how much is the glucose now, what is the target that I want to achieve, how much is the active insulin right now, and what additional correction should be given. And accordingly it gives. Now suppose there's a risk of hypoglycemia. Then the automated pumps, they reduce your bolus dose by 25%. And then it predicts whether this patient will have potentially hypoglycemia or not. If there's a risk of hypoglycemia, it will further reduce by 25%. Now the pump basics. External device about the size of a cell phone, and it is smaller than that. Continuously delivers insulin via indwelling subcutaneous catheter. It requires input from the wearer. It replaces injections. Operates on a AAA battery, the small battery, which I think can be replaced once in 30 days. It holds up to 300 units of insulin. And for patients who are on a pump, it is a 2 to 3 day stock. The insulin pump closely mimics normal pancreatic insulin delivery. Overview of the pump. So this is a AAA battery. It goes into this pump, and then you have this reservoir. It goes here, and this tubing is connected to this, and this infusion set ka cannula, this is on the patient's abdomen. So how does an insulin pump work? So it is a small computerized battery operated pump. It allows the user to control exactly how much insulin is delivered. There is a pump reservoir similar to a regular syringe. It holds 2 to 3 days worth of insulin. A thin plastic tube called an infusion set. It has a soft cannula or a needle at the end inserted just under the skin, usually on the abdomen. This tube is so firm, it is so strong that your pump can hang on that and it will not break. How does it work? Insulin passes from the pump reservoir through the tubing into the subcutaneous tissue. An infusion set is the link between the insulin pump and the body. That is this infusion set. This is the cannula housing. There is a wire. This is the cannula. It is similar to your IV cannula, but it is very small. The tubing and then the adhesive, and that adhesive is also very good. And the Center for Disease Control recommends changing the infusion set every 2 to 3 days. This infusion set should be changed every 2 to 3 days, so that there's no risk of infection and all. Insulin infusion, the skin, uske upar lacks your cannula and subcutaneous tissue, and insulin is coming down. It is going into the subcutaneous tissue continuously. So basal and on-demand dosing. So a steady infusion rate of rapid acting insulin adjusted according to individual needs during the day and night is the basal dose. I am not talking specifically about the most advanced pump. I am telling in general, where you can manually adjust. You can have up to 48 variations of your bolus dosing. You can tell specifically at 3 a.m. I want the insulin dose to be high. If somebody is having a nocturnal hypoglycemia, you see the trend and then you tell, here I want a lower dose. Throughout the day I want 1.2 units per hour. Here I want only 1 unit per hour or 0.8 units per hour. Something like that. So smart pumps can deliver up to 48 basal rates per day over scheduled, selected time schedules. There's a timer in the pump. There's a time in the pump, real time. And you can tell 2 a.m. to 4 a.m. only for these 2 hours, I want 0.6 unit per hour of insulin. And bolus also, the pump, what is the lowest bolus that the pump can give? So you have entered carbs. What is the lowest bolus that the pump can give? It's 0.0. Even if the user enters, I am having this carbohydrate, and if it knows that he is vulnerable to hypoglycemia, it is not going to deliver any insulin. 0.0 units insulin delivered. Okay, you will get the message. On-demand bolus dose, meal bolus to cover rise in glucose level from food, correction bolus to correct the glucose level above the normal range. You thought this patient will have 100 grams of carbohydrate, but he had 125 grams. And that 2.5 units was not delivered, due to which his sugar is going up. 180 is your cutoff for in range. It is going beyond 180, it touched say 250 also, 240 also. Then for that degree of hyperglycemia, it starts giving correction boluses. Those correction boluses are very small. It will not be like 1 unit, 2 unit also. It will be 0.6 unit, 0.8 unit. That is the kind of correction boluses, because already 1.2 unit of basal is going on. Despite that, it is high. So it gives additional 0.8, 0.6. Pumps are designed for multiple basal rates. So basal rates can be programmed to increase for dawn phenomenon. So here at this time specifically 4 a.m. to 8 a.m. I want a higher insulin infusion rate, or 6 a.m. to 7 a.m. rate. And basal rates can be decreased also, and higher rate can be programmed if needed after dinner. After dinner I want higher this thing. It can be done. So types of bolus doses. A bolus dose is an insulin dose given in addition to the basal insulin to correct an elevated blood glucose level. Corrective dose. Or to cover carbohydrates in a meal or a snack. Say you are not sure of how much carbohydrate this patient is going to take. How much bolus will you give to this patient? That is, what is the guaranteed food that this guy is going to take? It might not be 100 grams. You brought 100 grams, you are hoping he eats 100, but you are certain that he'll eat at least half of this. So you give 50 grams, you input 50 grams. So minimum guaranteed bolus should be administered. Uske baad mein correction can be done. And say for example, you forgot to give the bolus, and after 30 minutes patient remembers, I didn't have my bolus insulin. What is to be done? So if it is within 30 minutes, then you give half the planned dose. 100 grams patient was supposed to input. Now you input at least 50 grams. So this bolus, basal is that what is ongoing so that hepatic glucose output and interprandial sugars are maintained. Bolus is खाना खाने के बाद में जो sugar is going to rise, उसको control करने के लिए you need to deliver insulin, that is bolus. Or you have given the bolus, yet his sugar is high. So that correction dose that you give is also a bolus. That is what this statement says. A bolus dose is an insulin dose given in addition to basal insulin to correct an elevated blood glucose, which could be a corrective bolus, or to cover the carbohydrates in a meal or a snack, which is a meal bolus. Bolus doses can be standard, they can be extended over a longer time, eating over many hours, or a meal composition based on a meal composition. So, suppose this guy is having a burger, this fat, this carb, this protein, right? So in that you can give an extended bolus to this patient, or a combination of a standard spike and a lower longer bolus, such as a pizza bolus. So standard bolus is you give this spike, 10 units dena hai, deliver it right now. That's a standard bolus. Extended bolus is you give here square wave bolus. So this is not given as a spike but over 30 minutes. And a combination bolus where you give a spike, half 5 units you gave a spike, then the remaining 5 units you gave it like a square wave. And then the basal, so it continues. Benefits of continuous subcutaneous insulin infusion, practical advantages, multiple program features of pump, various basal and bolus types. Like I said, 48 rates you can set. Greater freedom with meal times and snacks. You just have to input I'm having this samosa. And possibly how many calories are there in that samosa? Take a picture, put it in ChatGPT, it will tell you 40 calories, whatever. And you have to input it in your pump. And inputting it is very easy. Your pump way, you just press this lower button, niche ka button, down button, and automatically you can enter the bolus. And spontaneity, lifestyle flexibility, patients no longer need to take multiple injections. Like you said, patient need not take 10 times, 5 times insulin, need not check 5 times sugars. And number of injections is reduced with continuous subcutaneous insulin infusion compared to MDA. So here it is 120 injections per month. 120 by 30 is 4 injections at least per day. But here it is only 12 insertions per month. And who are the candidates for insulin pump? Now, according to me, any patient, he could be Modi, he could be LADA, he could be type 1, he could be type 2, he could be FCPD, any diabetic who doesn't have a beta cell reserve and who is requiring multiple daily injections of insulin is an ideal candidate for a pump. And general recommendations for CSII across Europe usually include a combination of children unable to. So this, however, this is ideally for type 1 because in type 1, their C-peptide is less than 0.24. It is very low. They require multiple daily injections, right? So children unable to reach their HbA1c target level, recurrent hypoglycemia and hyperglycemia unawareness. The sugar is 300, they don't know. No symptoms. The sugar is 45, they don't know. And severe glycemic variability. Something like brittle diabetes. They do some exercise, they play, their sugar is low and they're just idle. They eat some sweet, the sugar is high. CSII can also be particularly beneficial in cases of dawn phenomenon, a fear of hypoglycemia, nighttime nocturnal hypoglycemia unawareness, needle phobias, low insulin dose requirement. Say this patient is requiring 0.25 unit per hour of basal insulin. It is very difficult for you to give that dose. Pump is where the patient will benefit from. And stress on the whole family, inability to self-inject. I have seen a mother who literally said, Dr. Saab, in turns, we would stay awake throughout the night and check the child's sugar with the fear that he might have hypoglycemia. Mother and father. And yeah, she cried when she told me that. The pump therapy has changed our life and we are very hopeful now of the child's future. Inability to self-inject the young children. General recommendations for adults, it is for usually include a combination of type 1 patients with poor glycemic control, unable to reach HbA1c levels, recurrent hypoglycemia and hypoglycemia unawareness, pregnancy or planning pregnancy, severe glycemic variability, type 2 diabetes on MDI with poor control. All of these, they become recommendations. What type of patient is appropriate for insulin pump therapy? The textbook candidate is somebody who is highly educated because there's a lot of sophistication in the device. Somebody who is highly motivated, who can get a reimbursement for the pump. He's spending then 2 lakh rupees, 2.5 lakh rupees for the basic pump and 6 lakh rupees for the automated pump. So somebody who gets a reimbursement. Somebody who is very adherent to the diet, who has a supportive family, who wants a good diabetes control, who counts carbs, who's on multiple daily injections. I have practically seen this. Consensus statement by the American Association of Clinical Endocrinologists or American College of Endocrinology Insulin Pump Management Task Force. The ideal CSII candidate is a patient with type 1 diabetes or intensively managed insulin dependent type 2 diabetes. Currently performing more than or equal to 4 insulin injections and more than or equal to 4 self-monitored blood glucose measurements daily. 7 might not be possible. There are people who do that. But at least 4. Pre-breakfast, post-breakfast, pre-dinner, post-dinner. Ideally it is pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner and bedtime. So if he is doing at least 4 breaks or is taking 4 insulins, motivated to achieve optimal glucose control, willing and able to carry out the tasks that are required to use this complex and time-consuming therapy safely and effectively, willing to maintain frequent contact with their healthcare team, then pump is for them. And the pragmatic approach is, first, if you have to identify a pump candidate, assess the need for CSII. Is the pump really needed and is it really going to create a phenomenal difference in the life of this patient if he is put on the pump? What is it in addition to what he already is doing, this pump therapy is going to offer to this patient? Should be the question that you ask yourself. Will my patient benefit? Is that investment going to offer the value beyond what he is already getting? And can my patient use a blood glucose meter? Can my patient use a mobile phone to assess the technical proficiency of the patient? Ask him, sugar check करने आता आपके? हाँ डॉक्टर साहब, नहीं डॉक्टर साहब बच्ची देखती. Oh, it's a red flag. Maybe it's going to be difficult for him. There has to be one person who constantly takes care of his pump if he is put on that. Can my patient use a mobile phone? Diabetes management skills. Does my patient count carbohydrates or quantify food? Can they learn to count carbs or quantify food intake? He might not be knowing it, how to count carbs. If you teach him, will he be able to count carbs and input it in the pump? And can they learn to deliver a bolus? For you and I, we are healthcare professionals. It is quite easy. I told you नीचे का बटन दबाना है and आपको enter करना है. You can do it. You might fail the first time, second time आप कर लेंगे. Will the patient be able to do it? Blood glucose enter करनी है pump में. Will he be able to do it? So CSII insulin pump is the most physiological method of insulin delivery currently available. The consensus statement on the use of insulin pumps from pediatrics from the SP, PES, ISPAD endorsed by ADA and ESD. This statement was given in consensus by all these societies. So what are the benefits of CSII? The clinical benefits is there's a reduction in hypoglycemia, there's reduction in HbA1c mean average glucose, the blood glucose variability improves, the insulin dose reduces. Because what happens is if a patient is on multiple doses, he may be taking more than usual, and in fact with the risk of hypoglycemia he might be doing a defensive snacking as well. But here with the precision with which the insulin is being delivered to the patient, the dose is reduced. I've seen a patient 120 units of insulin per day reduced to 80 units with the pump. Risk of microvascular complications. There's an improved metabolic control, there's satisfaction with therapy, there's improved quality of life and well-being. However, there are limitations. Long tubing connecting insulin reservoir to the infusion set, this can catch on objects and needs to be managed by the patient. But you can come into his pocket and this and that. The pump might fall. That is why I said it is so strong that it can hold the pump without kinking and all. Complexity of managing the large number of components required during setup and infusion set changes, insertion of the cannula is often difficult. Patient might find it really difficult. Elderly patients especially, कि एक सेंसर लगाना है and सेंसर को फिर ट्रांसमीटर को चार्ज करके उसको कनेक्ट करना है, एक कैन्युला लगाना है, रिजर्वॉयर चेंज करना है 2 दिन में, things like that, ट्यूबिंग चेंज करनी है, etc. So it is a little complex, but it is definitely doable. Limited locations to insert infusion sets. Infusion set, you can put it here, you can put it here. Maybe if somebody is pregnant, thigh pe laga do, etc. Cost is a factor. Risk of infusion set reactions. Highly visible device makes patient feel this is a constant reminder of their diabetes. Many patients might not know. Many people might not know what a pump actually looks like. And when the pump is attached here, he goes anywhere. People ask him, is that a hearing aid? What is that? What is this? Okay, he gets admitted to an ICU. Our critical care colleagues might not know how to operate a pump. They say, no, you remove it, we will manage it. We will manage your sugars. So he goes to an MRI. They're like, is it compatible? You transmitter nikal do, kuch hua to aapko nahi bola. So it is a constant reminder for the patient. And addressing some of those limitations. So patch pumps attach directly to the skin. This is a patch. No tubing, nothing. The pump attaches to the skin. And therefore do not require a line of plastic tubing to deliver insulin to the cannula. What are some of the main CSII models? Animas, One Touch Ping, Animas Wipe, Insulet Corporation Omnipod patch system. This is Omnipod. Medtronic MiniMed, 640G, and Vigo, the patch pump that I mentioned. Tandem is also popular. Roche ka acute check combo, acute check insight. Advantages and disadvantages relative to NDI. Now, it has its own advantages, it has its own challenges, but let us try to compare this CSII to a multiple daily injection regimen of insulin. So, advantages: tailored continuous insulin delivery, improved glycemic control, fewer hypoglycemic events, improved quality of life. There's no individual injections. It has the flexibility and the convenience. It is cost effective in certain patients. Disadvantages: often more costly. Why am I telling cost effective in certain patients? Because say a type 1 diabetic, vulnerable to hyperglycemia and diabetic ketoacidosis, one admission will cost them 1.5 lakh rupees. So if you are able to put that patient on a pump, forget about decay. Often more costly, risk of pump failure, and skin irritation at infusion site requires patient to be trained. And skin irritation, if he is allergic to the adhesive, then yes, you hardly can do anything about it. However, if it is because of prolonged indwelling catheter, this patient is not changing. 7 din ho gaye, 10 din ho gaye, he is continuously using it just because the pump is not giving any alarm. So that might cause infection, abdominal wall abscess. I've seen abscesses. Device attached 24/7 and psychological concerns also. The journey to closing the loop steps towards a fully automated closed loop system. So MiniMed Paradigm Pump, the foundation. This was the world's first integrated insulin pump and CGM system. integrated. This is not sensor augmented. MiniMed 530 system, 2013 to present, taking action. Smart Guard technology automatically stops insulin delivery when sensor reaches low limit. This is suspend at low glucose suspend, LGS. Then MiniMed 640 system to 2015 to present. Smart Guard technology includes new level of automation. This is predictive low glucose suspend before low. Hybrid closed loop system is HCL, where Smart Guard technology includes two new levels of automation: suspend before low and automated basal insulin delivery. And advanced hybrid closed loop, addition of the meal detection algorithm allows for more front loading of meal insulin and earlier delivery of correction post meal, improving interface and meal announcement. So meal announcement, just that down button for meal announcement. Pattern recognition. If the sugar was say steady for some time and is rising at more than 2 mg per minute, 2 mg per deciliter per minute, now it knows that there is some carbohydrate entry in the system. So it is able to detect that. It has a basic layer of AI, activity, food, heart rate, sleep, fatty acids, and detecting sensor or infusion set failure. It detects and tells you, check infusion pump, check the sensors, check this, check that. Okay, it can give you. Comparison of open loop, hybrid closed loop, and fully closed loop. So example is Animal's Y, Medtronic MiniMed 670G hybrid closed loop, and fully closed loop is Beta Bionics. I said right. Dexcom. Bionic pump is your alpha plus beta. Glucagon plus insulin. Basal dose is set by the user on HCD based on glucose readings. You and I adjust the dose. How much is his total daily dose? This much. Basal dose hum kitna de rahe? Say larger 20 units is being given. 24 units is being given. So based on that, you give 1 unit per hour of rate is set up to this patient. Manually it is set up by us. Here the PID algorithm from the CGM reading, it calculates in HCL. And it is calculated by the BD algorithm from CGM POs. Bolus dose, bolus calculator based on user estimate of meal carbohydrate content. I'm taking 100 grams, I input it. Wizard calculates dose based on current blood glucose and user estimate of meal carbohydrate content. So that bolus wizard, and here it is automatically taken care of. User input manually adjust basal and bolus dose. Here it sets bolus for meals and informs system of exercise. Temp target, you tell that I am going for an exercise. Here no input needed during normal operation. Automatic adjustments, no high or and low glucose alerts. It doesn't give any alerts. You have to manually check. Smart Guard HCL technology, threshold suspend, predictive low glucose suspend. It has this inbuilt feature. And yes, controls to target is what it does. CGM, the sensor is Dexcom G4 sensor in this Animas Y. Here it is Guardian sensor. Now we use Guardian sensor 4. And here it is Dexcom G4 Platinum. Here I wanted to tell you this PID, proportional integral derivative. This PID, where is it? Calculated by PID algorithm from CGM readings. So what the pump does is, when it is trying to give an autocorrection or a bolus or calculating a corrective bolus for a patient, then it sees how far from the target is the patient's sugar and for how long has it been there and how fast it has to come down. So based on that, this is the proportional integral derivative. What is artificial pancreas technology? So by mimicking some of the functionality of healthy pancreas, we are trying to close the loop. So body's response, glucose continually sensed and insulin automatically adjusted. So sensor continuously monitors glucose levels in the interstitial fluid. Insulin delivery is adjusted based on the sensor glucose reading. Adjusted insulin delivery results in changes in the body's glucose metabolism. Changes in glucose metabolism impact glucose levels in the interstitial fluid. So this continues. And paradigm VO, the first artificial pancreas technology, low suspend. Yeah, this works on the autopilot mechanism. Something like how our AC is working right now. What it sees is temperature kitna chahiye? 18 degree chahiye. How much is the temperature now? Kab se temperature was at this? And automatically it tries to bring the temperature down by giving more coolness and all. So the Paradigm View is the world's first insulin pump equipped with a low glucose suspend function designed to help prevent severe hypoglycemia day and night. Greater confidence that one can potentially avoid severe hypoglycemic episodes. LGS may reduce the number of trips to the emergency department. So just an overview, developments addressing the current limitation for CSII and CGM. Insulin delivery, patch counts remove problems of malfunctions in the infusion tubing set. Algorithms minimize hypoglycemia by automatic adjustments in insulin dosing. Threshold suspend, low suspend on low. It suspends insulin delivery for less than 2 hours when glucose sensor value reaches a predetermined lower threshold sensitivity. Say is 7. You have said that 70 is the lower target. Less than 70, my patient should not go. Once it touches 70, the delivery is stopped. Predictive LGS is stops insulin delivery if low blood glucose levels are predicted to occur. It resumes insulin delivery once glucose levels start to recover based on the sensor glucose. And control to weighing system is adjust insulin dose based on predetermined higher and lower CGM glucose thresholds, will not act on within range CGM readings. So here control to range. Ideally it wants that if it is 70 to say 180, it is not going to interfere. Okay, chalta rehne do. But if it is going lower than 70 or going beyond 180, that is when it acts. But the 780G, it acts at, starts acting at 150 only. Control to target system. So when you at 780G, adjusts and corrects glucose level automatically 24/7. Smart guard technology helps prevent highs and lows. Selection between a basal target of 100, which is the default setting. But if an elderly patient, you don't want hypoglycemia for him, say you said 120, you have set it at 120, or a child who is having hypoglycemia, you set it at 120. The auto correction target is set at 120. It helps prevent highs, gives you more insulin if you are trending high. So this is glucose level, this one. This is basal insulin. Right. Now sugar is at 170 and now it started giving auto corrections. The blue lines, auto correction boluses. Green is basal and auto correction delivered if the algorithm determined that they are needed, and it can be as frequent as every 5 minutes. Max basal should be reached. You kept max basal. His usual basal is say 1.2. You said max basal is 2 and 2 is being given, yet sugar is touching 180. Then auto correction starts. Max basal is reached. Glucose is more than 120. No automatic corrections if temp target is set. I told you, right? Temporary target. He's going for exercise. 150 was set. No auto correction will be given, even if it is 150. And then this helps prevent low also. Here, what did it do? It suspended the basal delivery only. Here, because it anticipated that it might go below 70. So here, at 90 itself, 80 itself, it suspended the basal insulin delivery. Bionic pancreas, by hormonal secretion, insulin and glucagon, integrated continuous glucose monitor, fully automated, control algorithm run on smartphone, insulin and glucagon secretion in response to CGM data every 5 minutes. Insulin bolus, priming based on bionic pancreas, definitely it helps at type 1. Who will be a more suitable candidate for a bionic pancreas? Which diabetic? Type 1, type 2, MODI, LADA, FCPD, GDM, which patient ke liye it is more physiological to have insulin and glucagon. DKE is happening because of unopposed action of glucagon. That is why type 1 diabetic will go into DKA, but FCPD will not. So this FCPD patient ke liye, this will be most physiological, apart from giving the exocrine supplementation. Insulin bolus priming based on qualitative assessment of meal type and size, and breakfast, lunch, dinner, typical, more than usual, less than usual, small bite. You just have to tell that. You don't have to quantify how much you're taking. Just, it is a typical meal. It is more than usual meal. It is less than usual meal. It is just a small bite. So I think all of us are going to have more than usual meal now. So CSII functionality, data download, key benefits. Data from most modern pumps can be downloaded to a personal computer or the internet, making it available to both patient and physician. And this is a very small image actually. So we have a big one. It gives you the ambulatory glucose profile, and it gives you a comparison of how this patient has done in these 15 days compared to the last 15 days. You get that. So the time in range and all. Allows self-education and simplified self-management. Enhanced patient healthcare provider communication. You can also have an ISIS, electronic academy. And patient is directly involved in downloading and interpreting glucose data. And it provides a roadmap during consultation for overcoming barriers to effective self-care and giving practical solutions. CSII aims to administer insulin in a pattern that more closely mimics physiological insulin secretion. CSII offers advantages over MDI, including better flexibility and control over basal insulin requirements and a decrease in daily insulin dose. CGM is a minimally invasive method that provides 24-hour glucose trends and the rate of change. It can be combined with CSII to improve glycemic control. So you are combining CGM and the rate of change also, so that the glycemic control is increased. CSII provides improved glycemic control, patient satisfaction and safety when used with CGM for patients with type 1 and type 2 diabetes. CSII use is increasing in patients with type 1 and type 2 diabetes due to advances in easy to use technology and clinical benefit. New technologies are being developed to achieve closed loop hormonal administration. That is an artificial bionic pancreas. So, thank you.